just a flesh wound. It's alive!
You can't handle the truth.
Go ahead. Make my day.
Say, all right, all right, all right.
Always live in awe of the glorious mechanism of the human body.
Okay, good morning, listeners. Today we are in for an absolute treat. I'm joined by one of my clinical heroes and somebody that I look really, really up to. He's single-handedly changed the way that I approach back pain specifically, and also my clinical skills in general as well. Today's guest is just going to be an absolute treat for everyone. I think if you're anything like me, grab a pen and a piece of paper and just write down everything you can and basically do what I'm going to do, and that's be a sponge and just absorb it all in. So our guest today is a Distinguished Professor Emeritus at the University of Waterloo. As a professor for 30 years, his work has produced over 245 peer-reviewed scientific journal papers. He's authored 5 textbooks and has also been awarded numerous international awards, including most recently the Order of Canada. He continues as the Chief Scientific Officer for BackFitPro, where he consults for low back pain patients and also works with some of the world's top athletes from various sports. So without further ado, please welcome Professor Stuart McGill.
Good morning, Jordan, and of course it's nighttime for me, but good morning to you, sir, in Perth.
Before we start, I just wanted to sort of give you quite a bit of praise in terms of your online course, which I completed at the end of last year. I thoroughly enjoyed your course. It was fantastic in the fact that because there's so much information and it's so densely rich with such clinical pearls. It was really great to be able to actually go back during the online course and rewatch some of those videos, some of them multiple times. I must have watched, I don't know, I can almost probably say it word for word, some of the stuff you said, because I would have watched it that many times. So I just wanted to give you a big thanks for the online course. It was brilliant.
My wife sends her condolences having to listen to me, but well, I'm glad you enjoyed it. I was so reluctant, Jordan, to put those courses online. I didn't really think people would learn in such a situation, but like yourself, they said, oh, we got to go back over the things that I went over a bit too quickly, which I can never predict who wants to hear things more than once. So they worked out well. There are 60 hours of listening to me demonstrate and play with patients and whatnot, as you know, and then there's the hands-on skills development sessions as well as an extra to my lecturing. And in a million years, I never thought they would be successful either, but they turned out. Of course, we had to adapt our teaching and be much more visual and descriptive, but the hands-on skill development worked out well. So anyway, thank you for the feedback.
Yeah, no, absolutely. And you know, again, courses in person are great, but being able to wake up early in the morning before I went out to clinic or anything like that and catch a couple of hours was great. So it was really quite useful how flexible it could be. And obviously, like we said, going back is really, really good because, you know, your numerous years of work, trying to condense that down to a couple of courses would be hard enough, but trying to, you know, absorb it as a clinician going in there, I think it was really, really useful. So moving on from there, I think we'll dive straight into, I'm trying to be respectful of your time, so we'll dive straight into the topics as well. So I thought we could start off with one of the big ones. We start off with the concept of spinal stability. So could you briefly sort of talk about the spinal stability and then discuss and explain this concept and why it's fundamental for function and also athleticism as well?
Yes. Well, stability has a definition that is context specific. So first of all, stability is akin to stiffness. So imagine a knee joint, for example. If you strain or tear a knee ligament, you lose stiffness in the joint and you get micro movements or shear instability. And of course, as a clinician, you would do a drawer test and test that laxity or loss of stability and whether or not that was a pain driver. So we can start off with that concept in spines. Stability is both a cause and a consequence of injury and pain. Isn't that interesting? It's both. So if we were to take, and you're familiar with the dynamic disc designs models, the great artist, the owner, who develops all of these, Jerome Fryer, took a lot of the initial models from our work at the university, and he captured in the most biofidelic way what we were able to measure over the years. So just as a knee loses stability and stiffness with injury, so do spinal joints. So consider this joint, L3-4 normal, and this joint, L5-S1 normal, but L4-5 has lost a bit of stiffness. Observe, I'm going to apply a torque back and forth, and you can see where the majority of the emotion occurs, where the joint has lost stiffness. If we turn around, you can see which facet joints are getting worked. Again, it's the joint. So not always, but almost always, if it's a non-traumatic injury, you will see the facets become clinical 2 or 3 years post disc injury. Very rarely is it a disc, is the disc secondary to facet damage. It does occur, but it's very rare. Nonetheless, there is the first tenet of spine stability. Injury causes instability and pain. And then if you could assess that through a frontal plane prone shear instability test, which is the drawer test for spines. You could do a frontal plane bear hug kind of a stability test where you push their shoulders, hooking down and posting as the clinician and pulling the opposite iliac crest across and seeing if you can create the pain laterally. But the beauty of this style of provocative testing is immediately you can find the antidote. You could ask the person, try some abdominal bracing, stiffen the abdominal wall, allow the stiffness of the muscles, excuse me, make up for the joint loss of stiffness, arrest the micro movements, try the offensive shear test once again, and quite often they say, oh, my pain is gone, or it's less. So there is the first type of stability in the context of injury. The next one would be, I've got models for this if you want to see it, but the spine is a flexible rod. Consider them as a stack of fruit. If we put a stack of oranges, one on top of the other, and put a book on top, most likely the oranges would fly apart. That's why we don't have ball and socket joints in our spine. We have discs. Discs add a natural stiffness. So they allow us to have reasonably modest musculature, because if we had ball and socket joints, we need enormous musculature around those stacked ball and socket joints. I used to run an experiment at the university in the classroom with 4th year spine students, and I would get a stack of coffee cans and I'd put a tennis ball in between each one. And then I had 4 guy wires, which were ropes, on each coffee can. And one student would be on one rope, and I'd say, all right, flex the spine. And they couldn't do it. The whole thing was buckling and collapsing until I put a rubber ring around each one, simulating the annulus, and then all of a sudden they could start to coordinate movements. So that's the second context and tenet of stability. The spine being a flexible rod is wonderful for dancing and tying your shoe. However, if you're going to pick up and suitcase carry your groceries, you better stiffen around that rod, otherwise it will buckle and collapse. If you're a power lifter, the supreme example of stiffness, they even put on an exosuit of stiff material to add even more stiffness to allow it to bear load. So stability allows a broad range of activities possible for the spine. That's the second tenet. The third tenet has to do with linkage mechanics. Our skeleton, our body, is a linkage. It follows the physical rules of linkage mechanics. The first one is proximal stiffness and control is required for distal athleticism. So if I want to wiggle my finger really quickly, I had to stiffen my wrist. Distal athleticism, I had to stiffen proximally. If I wanted to wiggle my hand, I had to stiffen my elbow. Finally, if I wanted to pull a door, throw a punch, or whatever, let's say I'm going to throw a punch, I'm going to use my pec major muscle, which crosses my shoulder, one joint. Distal to the ball and socket that uniarticular muscle creates the desired pushing athleticism. But look what it does proximally. It bends my rib cage towards, so there would be my effective push if all I used was my bench press pushing muscle. But if I lock down proximally, arrest the movement on the proximal side, which when we're measuring stability is an energy leak. We've lost energy. But when we lock down the proximal side, 100% of pec major is now expressed distally for the athleticism. So I can't even walk. If you go to the neurology ward at the Children's Hospital, and let's say you find a little 10-year-old girl with a paralyzed quadratus lumborum, a primary frontal plane stabilizer. Let's say her right QL is paralyzed. She can step with her right leg, plant, and lift her left leg for left leg swing. When she plants her left leg, the right pelvis now in leg swing collapses. Quadratus lumborum is there to hold it up. Proximal stability. If you don't have it, you can't walk very well. If you're a rugby player in Australia, if you're underpowered for core stability, say they're running in the pitch, they plant their left foot, cut and turn. And then we find, why do they get pain only during those high-speed turns? It's because they lack frontal plane training, and as they plant the left leg and cut, the right leg, the right pelvis just drops a little bit, tweaking whatever the sensitized tissue happens to be. But again, very context specific, but there are 3 basic contexts for stability, and we can go into others for combative athletes and protecting internal organs and all that kind of thing. But the big 3 for allowing movement and athleticism and dealing with this notion of stability being both a cause and a consequence of injury and pain, those are the 3 big ones. Sorry, that's a long answer, but that was a huge question that you just answered or asked, pardon me.
Yeah, no, absolutely. I mean, that's just massive, and you know, there's so much in there. It's brilliant the way that you sort of applied it to those 3 principles as well. And I mean, I know a lot of the time I say in clinic to patients, a great analogy. I'm a big one for analogies, and you know, you can't shoot a cannon out of a canoe. So you need to create that stiffness in order for you to do, like you said, anything. Move your finger, throw a ball, cut in rugby on the field. All of that applies to that stability. So that really does cover quite a bit of it as well. And I guess following on from that as well, the next question would be, I heard you often talk about the biological tipping point. So it's basically an overarching principle that governs the body. We talk about it often in clinic, not just in the spine or related to back pain, but I guess it could be applied to basically every injury that happens to the body, where we call it load versus capacity. So could you just explain a little bit about the biological tipping point and how this principle applies to injury rehab as well as also performance?
Yes. Let me go one level higher to start the framework. Every biological system has a tipping point. Let's take a nutritional one because everyone understands that. Let's take vitamin D as a variable, and it's a determinant of health. If you do not have enough vitamin D, you're deficient and you're sick. So you increase the vitamin D exposure either through nutritional supplements, or you get out into the sun, or whatever the case is, to the optimum level, and you now experience optimal health in terms of vitamin D. If you go past that optimum level, you now become poisoned and sick with vitamin D. In other words, there's an optimum level. That is the tipping point. The language of cells is mechanics, it's force. It's how they communicate with one another. It's how you strengthen bone, strengthen muscle, cause adaptations. It's how you regulate blood sugar. It's all of these systems in your body, all governed by tipping points. More is not better. Unfortunately, in today's society, you know, someone will show me a posting on social media, and this poor young person will say, Oh, on my day off, I just banged out 5K on a run, and that was my day off. And I think we'll be seeing you in the orthopedic clinic when you're 50, because you train to adapt. You adapt after the training is finished. And there are some people who just build cumulative micro trauma, not realizing it, because they never give themselves the rest for adaptation. And as you know, different parts of your body need different adaptation schedules. Bone, for example, is a 4 or 5 day turnover. So strongmen training, doing deadlifts and heavy squats and whatnot should probably, well, in real practice, what they do is they have a heavy squat day and they don't do it again for another 5 days or so. It's how you produce the grand old men and women of powerlifting and strongman. The bodybuilder trains 3 days a week. We had a patient here earlier in the week, and he said, well, I train every day. And my brain is, what are you thinking? Every day you just tear your body down. Why are you training? What are you trying to adapt? He had no concept of a tipping point and what he was really trying to accomplish. So that's the tipping point. And when you can understand that, your training goal is to manipulate the tipping point, expand the capacity underneath the tipping point, and avoid crossing it. And as you age, that tipping point will naturally decrease. So you have to recognize that. And the tipping point really governs your health so much. If you want an example, you see I've got a little bit of white hair now and I'm retired. And when I was your age, I was all about strength. I didn't need mobility. I had lots of mobility. I wanted to be strong. And that's the way I trained. I can't train that way now. I'd break myself. So with my injury history, or any older person's injury history, and the way that they are now functioning biologically, I don't worry about load anymore. I worry about the movement and the range of motion. And I mean, I tell you now, I have zero pain. I feel fabulous. I still split all my firewood and all the rest of it. But anyway, there's a bit of a discussion of a tipping point. It needs more context if we're going to talk about what their injury history is, what their anatomy is, their biomechanics.
Absolutely. I don't know if you're aware of Dr. Shona Halson, who's sort of a expert in recovery, if you will, particularly in Australia. She's worked with some of the top athletes from around the world, and also with the Olympic athletes from Australia as well. And a great quote that she always says is, the training you benefit from is the training you're recovering from. And I think that's so eloquent, and sort of sums it up as you're saying that, training is not where you get stronger. It's the training that creates a stimulus, which then when you put recovery, creates the adaptation, and that's where you actually improve from there as well. So it's a bit of a balancing act between, staying under that tipping point where you're pushing your body enough to actually stoke the fire, if you will, to create an adaptation, but then giving your body enough time to actually cement that adaptation.
Yeah, the only time you should really cross the tipping point is in competition. And you can go past the tipping point for a brief period of time. But once again, after you've finished the competition, you've earned an appropriate rest. There's the great powerlifter Ed Cohn. Many people refer to him as the GOAT, the greatest of all time. And Ed had a rule. He lasted many years. He only set one personal best, or maybe two, per year. And when he set a personal best, it took so much out of his body, he rested and let his body adapt. And he set record after record after record. And again, you see some of these people going to some gyms and they post their personal best on the blackboard, and they keep trying to better it every few weeks. And again, I suppose it's good business for you, but it's not the way to create a sustainable athleticism.
And sort of moving on from that, as you said, creating a little bit more, context specific, if we could sort of branch off into more specific injuries and conditions, something that we commonly see, probably the most common back-related injury that we see in clinic is disc injury or discogenic back pain. So if you could you speak about sort of the anatomy of the disc and how disc injuries occur, sort of the mechanism behind them?
So the disc obviously is not a ball and socket joint. There's a disc, which is a concentric ring architecture of collagen fibers. The collagen fibers are held together with a gooey stuff called ground substance. The middle of the disc is a gel, and it is an incompressible hydraulic fluid. There it is. And if you have, so I said the collagen forms a fabric. It's a biological adaptable fabric. My shirt is a fabric too. My beautiful Alico lifting jacket. I'll put a word in for one of the sponsors of BackFitPro here. If I wanted to work the fibers loose and create a hole in my jacket, I'd create stress strain reversals back and forth, and the weave would delaminate and open up. That's what people do when they start treating their spines like ball and socket joints. The collagen fibers with motion plus load, you need both. If I did cat camel or Middle Eastern belly dancing all day long, we've never measured any issues with that. The problem is when you take the spine through the range of motion under load. That's when the delamination stresses occur. And there has been a little bit of a delamination through the collagen here. So when I pressurize the nucleus, I can work the gel through the delamination, and you will, there it is. Do you see the bubbles starting to come up now?
Yeah, we can see
as
that,
the nucleus works its way through. So there is a fabric, and I'm just going to, everyone can see the weave. If I do some stress strain reversals, you can start to see how already I started to delaminate the fabric. So if we then go to another one of Dynamic Disc Design's brilliant models, you can see the gel down inside the nucleus, and if we look around posteriorly, you will see a delamination that has occurred. At the end of my finger right there, can you see a little bit of a red mark?
Yep.
That is a delamination. So now I'm going to squeeze the spine and bend it forward, which puts hydraulic effort posteriorly through the delamination, and then we can see the disc bulge starting. I have a friend who's a radiologist who has one of these in his neck, and he does this for about 15 minutes. We take an MRI picture. There's the nice juicy disc bulge. He goes the other way, and I'll pull a little bit of a vacuuming traction on his neck. 15 minutes later, it's gone. So there are certain disc bulges that we can have almost a spontaneous resolution with the right amount of mechanical knowledge, the disc shape, for example. The more limacon, or the more it's shaped like a lima bean, the easier it is to get resolution of the disc bulge. But then this is what happens. The next time the person bends forward, either performing a poor form squat in the gym, or they might, some people are even just tying their shoe, or they might sneeze and cause the disc bulge to grow. Bending forward, and you can see the bulge growing. Now, this time I'm going to apply the mechanical antidote. We're going to stack the spine, and I'm going to bend forward through the hips. You can take a lot of compression now, and I'm just going to compress. Notice nothing comes out of the delamination. You have to bend forward and drive the hydraulic effort posteriorly with posture. So posture is key in that type of disc bulge. So that's one way, almost always associated with lifting poorly. If we had a very flexible athlete, say someone like a yoga practitioner, and they didn't lift weights, interesting, when they bend forward, their disc bulge is anterior. Or to get a posterior bulge, they have to arch backwards. So it's the opposite response, because their discs have adapted great flexibility and they're not delaminated. So do you see how, again, how the disc was adapted by its owner determines the disc bulge and the disc damage. Another pathway, though, is through the top and bottom of the disc. Consider the vertebra as a barrel, and the top and bottom of the barrel is a cartilaginous end plate. It's not bone as people think. So now I'm going to squeeze this specimen, pressurize the nucleus inside the disc, and now we've cut the top of cut the vertebra off. But notice how the end plate squeezes up into the vertebral body. And the vertebral body is not solid bone, it's spongy bone, cancellous bone. And those struts or trabeculae of bone have a spring, a leaf spring action to them. But this breach in the cartilaginous end plate allows the nucleus to come through and push into breaking some of the struts, and that's called the Schmorl's node. And the inflammation response to the immune system seeing the nucleus come through into the blood for the first time, because the nucleus is avascular, doesn't have blood supply. But as that nuclear material comes up into the bloody environment, it sets off a massive inflammatory response, and then you see the modic changes on MRI, which is inflammation inside the bone, and it feels like a bone pain. So when the person says, "Oh, I've got," they can put their finger on it right there. I've got just a central boring pain, and I'll say, "Good, grab the stool, pull up on the stool, add some compressive load," and I'll say, "That's what really triggers my pain." So now we're suspecting an end plate fracture. When you let a little air out of your car tire, it bulges on the road, and the car is also a little bit sloppy. That's what happens when you get an end plate fracture. The whole disc bulges now, and it's not a focal disc bulge, which I've been talking about up until this point. It's a broad-based bulge, because the whole joint is now flatter and the disc just bulges everywhere. Not only does it bulge outward, but it bulges inwards as well. And over the longer term, that may be a bit more of a problematic clinical situation. Anyway, there's a little bit of a start or essay on disc injuries.
Yeah, again, so rich. There's so much in that, and I think it's great to actually, be able to visualize it, which is why I'm a big fan of those dynamic disc designs as well. I think, we'll touch on it a little bit later, but being able to actually educate patients on that, so they actually, know their mechanism, is so empowering, and I think it's huge as well to go on that. Just following on from those disc injuries, does that disc injury, if it loses, as you say, like a car's tire, sort of depressurized, is that what can result in micro instability? I know you sort of mentioned that early on.
Yes.
Is that what we see happening with it?
It certainly can do, yes.
And so
sometimes yes, and sometimes no. Sometimes, as you know, it could lead to an anterior listhesis or a posterior listhesis, and kink the spinal cord and the cauda equina and all kinds of things. So it really sets off a whole possible cascade scenarios.
Great. And I think a real a point that needs to be highlighted as well, as you said, when you're working those fibers apart, so it's more of a delamination. Those fibers actually spread apart as opposed to completely rupturing. Is that correct?
Very rarely do you see ruptured collagen. When you do see ruptured collagen, it's not that the collagen was torn in the middle. I have seen it in some extreme twist injuries, but it's extremely rare. When we see collagen that is disrupted, it's usually the collagen fibers connect to what are called Sharpie's fibers, and that's what goes into the bone of the vertebra. And we've seen where the bone breaks and rips out the Sharpie's fibers, and now that section of the collagen actually is only connected at one end. So the fibers didn't tear, they ruptured out of the bone that they were connected to at their end point.
Wow. Yeah, that sounds pretty brutal. That's for sure.
Yeah, well, that is usually in heavy compressive injury, where you're fracturing the bone and the end plate and the growth plate. You see it much more often in elderly and the adolescent spine.
And so, building on from that micro instability or micro movements as we see there, this theory of atherogenic or neuromuscular inhibition is a very interesting and fascinating principle to me as well. Now that I've sort of, as we said earlier, gone through a lot of the studies and reading a lot of research around it, I'm starting to pick it up quite a bit more in my low back patients, particularly those who've had low back pain ongoing for quite a time. Could you sort of explain this principle of neuromuscular inhibition and how it applies to low back pain?
The first I had really been exposed to it was from the work of Vladimir Janda, who is the Czechoslovakian neurologist and a student of Karel Levitt. Janda proposed this reaction in not everyone, but in quite a number of people with chronic low back pain. The back pain inhibits the gluteal muscles of the hip, and it facilitates the hip flexors. So on one side, you've got overactivation, shall we say. Now, he called that having a tight muscle in the hip flexors. And the sign of it was the person got out of a chair and they would have to walk their hands up their thighs and slowly pull their hips through because of their perceived tightness. So that was facilitation of the hip flexors. And the gluteal muscles became inhibited. So you've got several options to extend the hip. You can use the gluteal muscles or you can use the hamstrings. And he had various tests to show that when the person extended, they would do it with their hamstrings rather than their gluteal muscles. Well, of course, if you don't have gluteal muscles, that puts extra load on both the back and the hip if you go through the mechanics of that. And probably the best work on that would be Carol Lewis and Shirley Sarman of St. Louis. But going back to Janda's neurological reaction to pain, he didn't have electromyography and the techniques to confirm or refute this, but it was his clinical observation. And he was sort of like Einstein in a way, in that he had many predictions and understandings of various pathologies throughout the body, but not always the equipment to prove it. So we did have electromyography at the university, and I believe we were the first to measure this phenomenon. So we took a group of people who were candidates for hip replacement in about 5 years, but they were still working, firemen, policemen, the trades. They had an arthritic hip, but it wasn't just bad enough yet to replace. So there was an interventional radiologist at one of our hospitals where he would do a therapeutic arthrogram. He would pump a saline fluid into the joint capsule of the hip. That hurts. I've had it. I've had it in my shoulder and in my hip. And it bursts the capsule, expands it just a little bit. So first of all, we measured the people walking, doing back bridges, lifting the hips up off the floor where they should be engaging the gluteals. That would be a very healthy response. When we gave them hip pain, they didn't use their gluteals near as much. They became very, very hamstring dominant. And then when the pain went away, the neurology returned. So it was the first inkling that Janda was right. Now, not in everybody, but a lot of people. So it causes people to limp. If you have knee pain and you're anticipating it, the brain inhibits certain muscles and you limp. So it makes good sense. Now, the other side of the Janda crossed pelvis syndrome, as he called it, was a neurological facilitation of the hip flexors. Well, as it turned out, it wasn't the hip flexors, those candidates being rectus femoris, the high quadricep, iliacus, and psoas. So we put intramuscular electrodes into psoas. I was one of the first guys ever in the world to have my psoas implanted with an electrode to see what challenges, hip flexion, spine stability, whatever, when does the brain go and get the psoas muscle? But anyway, it turned out it was just to the psoas muscle, this facilitation. Well, people can do hip flexor stretches in the clinic. They might grab their ankle and do all kinds of stretches for the hip flexors. That might stretch the hip flexors. It does nothing for the psoas. You can palpate the psoas. So there is rectus femoris. There's my inguinal crease. I'm going to drift my fingers just into the medial little notch, the iliopectineal notch. And now I can go into a lunge position and I can feel my psoas tendon now, and it's not tight. But if I descend a little bit more and then I push my arm overhead and I reach for the ceiling, now all of a sudden I can start to feel psoas becoming stretched because I'm bending my spine. Psoas comes all the way up the spine, up all the transverse processes to the diaphragm at T12. And then I drop my shoulder back. Now all of a sudden, psoas becomes active. And now I'm going to spin my hand around into internal shoulder rotation, external shoulder rotation, playing with the anterior chain fascia. And in some people, that causes tremendous psoas tightness, and that will release it. So, boy, what a lot of examination I just did to determine, is it psoas? And if so, I just found a very specific stretch for the psoas muscle, but it only begins there because the psoas, as we've learned so much from the work of brilliant people like Thomas Meyer, for example, following these anatomical trains, connecting many groups of muscles and slings throughout the body, that I can now stretch my psoas depending on where my hand is over my head. And as I said, some people, it induces a lot of tightness and pain, and sometimes it takes it away, but that's the first stretch that has been able to alleviate the neurogenic facilitation of their psoas. It's not their hip flexors. So we learned so much from Yonda, but as is often the case, a little bit more refinement and investigation of the phenomenon takes us to better clinical understanding and better clinical tools to help these people suffering from those very specific types of neurological reactions to pain. Sorry, I get wound up and I talk too much. That's again probably far too long and disorganized.
No, not at all.
I hope you got it.
Yeah, no, it's brilliant. The more, the better. As I said, just going to be a sponge and try and absorb it all. So as I was going down there, I was just jotting some things down as well. But following on from that, is it in order to address that, we're not only stretching the psoas as well, but it's also getting some more facilitation of the actual glutes or the muscles that have been inhibited. Is that correct?
Absolutely correct. We tested different techniques to reintegrate the sleepy gluteals. I used to use the word gluteal amnesia. Some people thought that was very funny. And there would be clinicians who would take a med ball and they'd use some techniques where they'd say, well, let's go around the clock. I'm going to flex with the med ball, and then I'm going to extend to 6 o'clock, 5 o'clock, 4 o'clock, and go around the clock with this ball, saying this would activate the gluteals. Well, we took some gluteal inhibited people and we tried those. It didn't, they were hamstring dominant before the exercise, and they were hamstring dominant afterwards. It didn't re-educate the brain. And with Yonda's exercises, we would do, we'd have the client lay on their back, and then they would create sequences to activate the quadriceps by pushing through knee extension, and then doing a back bridge, mentally thinking of activating the gluteals. And then we would monitor the co-contraction of hamstrings. And through proper coaching, and this was all Yonda's techniques that we would coach, that was the most effective way out of all of them that we measured for re-educating the engram, which is the collection of signals for hip extension, where prior the glutes were missing in the program, but to re-educate the program and do it enough times that you've created a new muscle memory, a new engram, where the gluteals are now dominant once again. Now, there are some athletes, for example, that don't really use much gluteals at all. They are very hamstring dominant, and a bike cyclist would be one of them. Massive hamstrings, quadriceps, not much glute. And it's very difficult to re-educate those people because of the strong engram that they've developed with the cycling. But for most people who don't cycle, it's not that difficult to create the more normal engram post pain if they've been gluteally inhibited.
Fantastic. And I guess, there's so much there again. There's just so many clinical pearls. It's fantastic, but it goes back again to identifying the right cause, doesn't it? I mean, if it's just purely a tight muscle, stretching may be beneficial, but it's understanding the whole context to it, that, that's almost a consequence of what else is going on from there. And then applying the right fix to the right cause is going to get you the most benefit.
Yeah, absolutely. And I did a lecture this morning, and my point was everybody is different. You can't train a Saint Bernard to win at the greyhound track, even though they're both dogs, and you will never get a greyhound to carry the loads up a snowy mountainside the way a Saint Bernard can. And people fall into the same category. So what works for some people who have a very dominant fascial train. They're very elastic people. These are the people who throw javelins and high jump and that kind of thing. But they're not the power lifters who take all of the elastic in that sense away, and to create stiffness and load-bearing ability. So, these conversations always require a context
Absolutely.
to be consumable. And unfortunately, in this day of social media and 2 or 3 sentences to explain your point, the context is often missing, and it causes so much unnecessary division, I suppose.
And that brings an end to part 1 of our podcast interview with Professor Stuart McGill on all things lower back pain. If you haven't already, I would suggest going across to our social media to take a look at the video version of this podcast interview, as Professor McGill often uses models and different visual tools to assist with explaining some of the various topics. So I really highly recommend going across and looking at the video version, as it will make just a little bit more sense if you can actually look at it visually. Other than that, if you haven't already, please consider subscribing to our podcast, liking and sharing, as it does help to spread the word of the podcast and get the information out there to the populations. In the meantime, keep an eye out for part 2, which will be coming out soon, and again, chock full of great information. Until then, keep healthy, keep learning, and keep doing what you love.